Hi, my name is Atif Darwish, Professor of OBGYN, Asyut University, Egypt. The talk of today is about adenomyosis uteri, and previous publications and previous textbooks mention that adenomyosis is a form of endometriosis. It is internal endometriosis, and the well-known endometriosis, which is pelvic endometriosis, is called external endometriosis. This is an old classification, and in the modern practice does not exist because they are not similar entities. They are different, completely different in the pathogenic pathway, in the type of patient, symptomatology, lines of management, and the complications, despite being associated together in many cases. Up to 90% or 80 to 90% of cases you may find endometriosis and adenomas, but still there are many differences between these two entities. So we have to discuss adenomyosis as a separate disease, not linked to pelvic endometriosis. Adenomyosis is heterotropic endometrium, like heterotropic pregnancy, which means intrauterine pregnancy and extrauterine pregnancy. So we have endometrium intrauterine lining the normal endometrial cavity, and extraendometrial, which is embedded inside the myometrium. And the adjacent myometrium is not innocent. It shows hyperplasia, so the uterus will be enlarged in size due to the muscle hyperplasia or myometrial hyperplasia and the implanted endometrial tissues. Why this occurs? This occurs because many theories explaining this, but the commonest and most logic theory is that the zona bisalis, which is the basic layer of the endometrium, invaginate inside the myometrium due to destruction or alteration or interruption of the junctional zone. This is a basic etiology, or the most common explanation of why the endometrium left its place and goes inside the myometrium. We should know what's junctional zone. Junctional zone anatomically is the inner third of the myometrium, near to the endometrium. The outer third is an inert part of the myometrium. The inner third is the active part of the myometrium. It is architecturally and functionally different from the outer third, two-thirds. It is the origin of myometrial contractions, which are responsible for different mechanisms in infertility and in bleeding, as proved by thin MRI studies. Functionally, the junctional zone is a highly specialized hormone responsive structure located in the inner third of the myometrium. So it is not just the inner third, it is a very active inner third with a lot of production of hormones and so on. It's very important layer, and thanks to MRI we diagnosed this part of the uterus, and we concentrated on it in this very important topic. So the topic of adenomyosis has been improved markedly in literature after the introduction of MRI evaluation of the myometrium and its division into inner third, which is the active part, and the outer two-thirds. Now, what happens with a patient with invagination of the endometrium inside the myometrium? This is common in patients with a history of trauma to the endomyometrial junction. When this trauma occurs with childbirth, so this disease is common in multiparous women, with cesarean section, of course, with prior myomectomy or other hysterotomy or other uterine operations, with termination of pregnancy, evacuation, curettage, and so on. So any intervention with the normal endomyometrial junction and destruction or alteration of this junctional zone by intervention, whether natural or iatrogenic, is the cause of the adenomyosis. And this is actually one of the theories explaining why adenomyosis occur. Why does it occur? So it is called tissue injury and repair theory. Tissue injury and repair theory. But others mention that the adenomyosis is an estrogen-dependent disease, so it is commonly seen in patients who have a lot of estrogen. Reproductive age is common around 30-year-old, and in women with early menarche, short menstrual cycles, obese with tamoxifen use. And one of the suggested possibilities, the occurrence of depression and use of antidepressants in some studies. Now what happens? The uterus, if you examine the patient or see her by ultrasonography, you will find the measurements of the uterus increase, and this is the gross appearance of the uterus. If you do hysterectomy, and this is the hysterectomy specimen, the myometrium is enlarged, hypertrophied, whether symmetric or asymmetric, and you will see glands inside with foci, with hemorrhage inside, and this is the gross appearance of the uterus, which does not mistaken with other abnormalities. If you take a biopsy, you will see endometrial glands and stroma surrounded by hyperplastic myometrium, which is adenomyosis. In most cases, around more than 50% of cases, the adenomyosis is diffuse in the whole uterus, but sometimes it is cystic in 4% or 5% of cases. Sometimes it is localized, nodular in around 30% of cases, and sclerotic in around 13% of cases. So you may see diffuse adenomyosis, you may see localized, you may see cystic or sclerotic adenomyosis. Now, is it a frequent disease? Can I see it in my day practice? Yes, you can see it if you concentrate on this disease, if you put it in your mind. This depends on your clinical sense. During examination of the uteri, you should train yourself on the examination of normal sized uterus and abnormal sized uterus. What is the cause of abnormality? You have to search for this. This is number one. Number two, if you do ultrasonography, you can see it in around 20% of cases by ultrasonography. If you are dealing with an infertile patient and preparing her for assisted reproductive technique, you may find a prevalence of up to 25% of cases. Patients with endometriosis, up to 80% of cases, you may see adenomyosis in those cases. And if you do hysterectomy, don't ignore to open the uterus to see what's inside the cavity. And what about the myometrium? You can see in the hysterectomy specimen adenomyosis in the uterus in up to 35% of cases. So you can diagnose adenomyosis frequently if you put it in mind. Nowadays, we observe an increased prevalence of adenomyosis. Why? Because of increased diagnostic tools of adenomyosis. Nowadays, ultrasonography, whether two-dimensional or three-dimensional ultrasonography, can easily diagnose adenomyosis. MRI played a very important role in understanding of adenomyosis and its mechanism, and this is very important. Now we have a patient at the outpatient clinic with adenomyosis. Do all patients will present with complaints? No. 1/3 of our patients will be asymptomatic, no symptomatology. Just 2/3 will start to complain. Complaint will be pain. In most of cases, this pain may be chronic pelvic pain, more than 6 months, acute pelvic pain, which is characteristically will be piercing, scalpel-like pelvic pain, very painful, very agonizing, and sometimes the pain is dysmenorrhea, congestive dysmenorrhea, dyspareunia, dysuria, dyschezia, and muscle pain, generalized muscle pain due to anemia and exhaustion of this pain, and bone pain also due to anemia and generalized general bad condition, because this disease affects the patient's life, quality of life will be impaired, and it definitely has a negative impact on the woman's quality of life. Another category of complaints will be abnormal uterine bleeding, and this is seen in the palm coin FIGO classification, and P is polyp, A is adenomyosis. So it has been put by the FIGO as one of the causes of abnormal uterine bleeding, and the abnormality may be menorrhagia, spotting, metrorrhagia, and you may find combination of pain and abnormal uterine bleeding together. Other symptoms may be irritable bowel syndrome, irregular bowel movements, nausea, fatigue, mood changes, insomnia, and depression due to the heavy bleeding, due to severe pain, agonizing, piercing pain. And you may have a case with infertility and adenomyosis, or you may have a case with bad obstetric history due to preterm labor, due to abortions, due to preeclampsia, due to any bad obstetric abnormality outcome, also can be attributed to adenomyosis. Regarding infertility, how adenomyosis would be seen as a cause of infertility? This can be explained by abnormality of the uterotubal transport inside the uterus. So transport of sperms will be impaired due to increased intrauterine pressure, due to dysfunctional hyperperistalsis, due to anatomic distortion of the uterine cavity. So the process of fertilization will be affected due to abnormal ascent of the sperms and transportation to the ampullary part of the fallopian tube. Another explanation for the infertile cases is the altered endometrial receptivity by the uterine contractions, by the increased intrauterine pressure, which may lead to impaired implantation. So infertility can occur in cases with adenomyosis as well. What about the pregnancy outcome? I told you it can lead to preterm labor, premature rupture membranes, increased risk of cesarean section delivery, small for gestational age, postpartum hemorrhage, fetal malpresentation, second trimester miscarriage, preeclampsia, and placental malposition. All these are some studies publishing the adverse effect of adenomyosis on pregnancy outcome, may be explained by inflammatory process associated with adenomyosis, increased myometrial prostaglandins, altered contractility and peristalsis, or increased uterine intrauterine pressure, as I told you before. Now we have a case in the outpatient clinic. What can I see in the clinical examination? You should concentrate on the uterus. It is a disease of the uterus. So examination you may find a large sized uterus, which is called bulky uterus, and characteristically it is very tender, extremely tender when you do BV examination, and this tenderness is characteristic for adenomyosis. Don't forget to test a case with adenomyosis to see how much pain expressed on the faces of this patient, and this is called Halpin's sign. Halpin's sign is severe agonizing pain on bimanual examination of the uterus. This is very important in addition to increased size. So we have to examine the patient by two-dimensional ultrasonography, by transvaginal. You may see the myometrium enlarged symmetrically or asymmetrically. The uterus is globular in shape with thickness and characteristically trabeculation or of irradiation inside, like fan shape inside the myometrium. So these are possibilities of ultrasonographic findings, include asymmetrical thickening of the uterus, intramyometrial cysts or hyperechogenic islands or both, fan-shaped shadowing, myometrial due to shadowing due to the gland branching inside the myometrium, myometrial echogenic subendometrial lines and buds, translesional vascularity, and irregular or interrupted junctional zone. And this is a picture of localized lesion with areas of decreased echogenicity and heterogeneity of the myometrium, which is seen in more than 25% of cases. If you use your Doppler machine, you will find increased myometrial vascularity in cases of adenomyosis, whether localized or diffuse. The increased myometrial vascularity is a characteristic Doppler finding in all cases. Again, MRI is the key of diagnosing adenomyosis, and It is the tool that helped us to understand adenomyosis in the current practice well. In the mid-sagittal slice 2T, you will find normal endometrium appears as homogeneously hyperintense due to increased fluid content, vascular content inside the endometrium, and in the adjacent myometrium there is decreased vascularity or water content, which is the inner 1/3 of the myometrium, which is the junctional zone hypointense area. Again, the MRI, you can see some bright foci seen in areas with abnormal low signal intensity within the myometrium in approximately 50% of cases. These foci may be heterotropic endometrial tissue, cystic dilatation of heterotropic glands, or hemorrhagic foci inside the myometrium as seen in these pictures. Now, what is the diagnostic criteria for adenomyosis by MRI? The MRI mentions that junctional zone, which is the active inner third of the myometrium, should be less than 8 millimeter in normal uteri. If it is more than 8 millimeter, it is a case of adenomyosis. You can diagnose adenomyosis if the junctional zone is less than 8 millimeter, provided linear striations are seen inside this area. If not seen, it is not a case of adenomyosis. So the cutoff level is 8 millimeter. If it is less, it is not adenomyosis. If it is more, between 8 and 12, it is adenomyosis. You may find adenomyosis by when you are doing laparoscopy for another cause like pain evaluation or infertility assessment. And adenomyosis, if you do laparoscopy, the first point to alarm the adenomyosis diagnosis by laparoscopy is the fixed RVF uterus, the heavy uterus, the bulky uterus by ultrasonography, by laparoscopy, and you have to push the uterus anteriorly to the uterovesical pouch to see the Douglas pouch because it cannot be seen by the trocar in the umbilicus unless you use another instrument. Sometimes the uterus is symmetrically or asymmetrically enlarged, and you may, if you have a previous ultrasonographic diagnosis of a cyst inside the uterus, you may make hysterotomy or incision of the uterus by a needle, and you may see chocolate material of the retained menstrual blood inside the endometriotic tissues inside the uterus, which are adenomyosis, and the hemorrhagic cysts can be drained by laparoscopy. Also, if you inject dye inside the cervical canal to test for tubal patency, the dye may go to the myometrium, not to the fallopian tube or with the fallopian tube. This is because of the invagination of the endometrium from the endometrial cavity into the myometrium, and this is called the blue sign, which is a pseudo widening from the adenomyosis, and this is a sign published by some authors. So these are the criteria by laparoscopy. You can see a localized cyst by laparoscopy. If you have a good sonographic diagnosis, preoperatively you can incise it and drain what's inside. This is a big adenomyotic uterus, as I told you. Now we will do hysteroscopy for this case because she is an infertility case or abnormal uterine bleeding case. We'd like to evaluate what's inside the uterine cavity. If you go by hysteroscopy, you can see some abnormalities that may alarm the diagnosis of adenomyosis, like superficial openings of the endometrial cavity suggesting disruption of endomyometrial junction, endometrial hypervascularity, which is seen if you minimize the pressure inside the uterine cavity a little bit, and you can see cystic hemorrhagic lesions bulging inside the endometrial cavity, and sometimes you can open these lesions as seen in these pictures. You can open them by a microneedle to drain the hemorrhagic content of these cystic lesions. All these possibilities are guided by a In this video, we perform hysteroscopy for any case of suspected adenomyosis with abnormal bleeding infertility or pelvic pain. And you can notice that the endometrium has been changed into black dotted appearance, which means invasion of the myometrium by these endometrial glands and stroma with retained menstrual blood inside these foci or dots of the adenomyosis. And this is a very interesting view of the endometrial cavity in cases of adenomyosis. If you see a lesion like this via hysteroscopy, hysteroscopically guided biopsy is mandatory to rule out adenomyosis and to complete treatment for such a case. And we performed an old study on role of hysteroscopic biopsy in cases of adenomyosis, and we succeeded to take a biopsy via hysteroscopy in all cases. Now we have to differentiate between adenomyosis and endometriosis, adenomyosis and leiomyoma, adenomyosis and endometrial carcinoma, adenomyosis and myohyperplasia. The most important is to differentiate between adenomyosis and endometriosis. Both are related to hyperesteranism, but adenomyosis is a local invasion of the myometrium by the endometrium. So the endometrium goes inside the myometrium, but in endometriosis, it is a pelvic endometriosis, which means that the endometrium goes outside the endometrial cavity elsewhere, and it may affect the abdomen, the pelvis, and so on. The frequency is variable in both diseases because of different factors affecting the prevalence, like age, like pain, like infertility, and so on. The patient in adenomyosis usually is multipara and older than that in the endometriosis group. The endometriosis is commonly seen in the nulliparous women and usually in the childbearing period and young women. The main complaint in adenomyosis is central piercing, pelvic pain, dysmenorrhea, abnormal bleeding, and sometimes infertility. But in endometriosis, different types of pain, special type of dysmenorrhea, infertility, and abnormal uterine bleeding. Regarding the history, in cases of adenomyosis, there is a history of uterine surgery with damage of the endomyometrial junction, and this has been achieved in many cases by deliveries, normal deliveries, by cesarean section deliveries, by pregnancy termination, evacuation, curettage, tubal ligation, and so on. But in endometriosis, there is a history of pelvic surgery due to recurrence of endometriosis, as it is a recurrent disease, and there is a family history in many cases, particularly sisters and mothers. They have a good relationship regarding the prevalence of endometriosis. Of utmost importance to differentiate leiomyoma from adenomyoma. Why? Because leiomyoma is liable to be surgically excised due to the presence of pseudocapsule, and differentiation of the tissue planes is easy, while adenomyosis is surgically very difficult due to absence of a pseudocapsule. So from the beginning you have to differentiate between leiomyoma and adenomyosis. The leiomyoma is well demarcated due to the pseudocapsule, homogeneous echogenicity due to the whorly appearance, usually localized, single or multiple, but localized. The Doppler shows increased vascularity, and there is uterine or endometrial surface irregularities according to whether the myoma is subserous or submucous. Now we have diagnosed the case of adenomyosis, and the patient asks to have a good treatment. We should differentiate according to the patient's complaints, according to the age, and according to the reproductive status. Not all cases are treated the same. If we have to classify the lines of treatment, we should have medical treatment, hormonal treatment, and surgical treatment. Medical treatment for patients with pain, we can give analgesics For anemia due to heavy bleeding, we give iron supplementation, tranexamic acid to minimize the amount of bleeding, and menorrhagia or metrorrhagia at the same time, non-steroidal anti-inflammatory drugs, and others. We can give the patient hormonal treatment. The famous hormonal treatment is combined oral contraceptive pills. The COCs are very effective for relief of pain related to adenomyosis, but they are not well settled as a line of treatment of heavy menstruation with fibroid or with adenomyosis. It induces pseudo-pregnancy, so it is a good option for pain control. Of course, for patients who do not desire fertility, the same applies for progestins. We can give high dose of progestins and prolonged duration of progestins to achieve subsidence of symptomatology of pain and bleeding. And the best progestin is Dienogest, which had some randomized controlled trials and proved efficacy in controlling pain in those cases when it is given for a long time, up to 16 weeks. Other progestins like norvesterone acetate, all these progestogens are working by being anti-proliferative and anti-inflammatory with decidualization and atrophy of the endometrial tissue. We can give progesterone locally to the uterus, and by this way we save the patient from systemic side effects of progesterone by inserting a levonorgestrel-releasing IUD system inside the uterus, which is principally used for contraception, but we can use it to control bleeding and pain, and prove to be effective to control both with an overall satisfaction rate of 72%. Also, we can give a hormone which is gonadotrophin releasing hormone. It can be given before IVF ICSI cycles, and it is very good in such cases because it had been reported that a high pregnancy rate was achieved in those cases received GnRH agonist before embryo transfer of frozen embryos. But if we give the GnRH analogs for women with pain and bleeding, it should be short duration, because if you give GnRH agonist for a long time, it may have deleterious effect on the woman's health, like osteoporosis and other side effects of prolonged use. So GnRH agonists are effective in reducing adenomyosis, pain, uterine size, and controlling bleeding, and may facilitate fertility as well. Some drugs are under trial, like selective progesterone receptor modulator, aromatase inhibitors, valproic acid, and antiplatelet therapy. Now, what about surgical treatment? Surgical treatment can be conservative surgical treatment or radical surgical treatment. Previously, the ultimate and definitive treatment of adenomyosis is total abdominal hysterectomy. But this line of treatment is offered for women who completed their families and are not willing to have babies. But women willing to have babies should have a conservative surgical treatment after failure of medical and hormonal treatment. The conservative surgical treatment can be hysteroscopically made or laparoscopically made or by open surgery. Hysteroscopically, we can do endomyometrial resection. Endometrial ablation is not sufficient to treat a case of adenomyosis, because endometrial ablation, you coagulate the endometrial cavity. This is not the problem. The problem inside the myometrium, where endometrial glands and stroma invaginate inside the myometrial wall. So we can offer our patients what's called TCRE, which is transcervical resection of the endometrium and the myometrium. So it is TCREM, which means endometrium and myometrium resection. We cannot excise the whole myometrium. We should excise a part of the myometrium which is adjacent to the endometrium. So the endomyometrial resection should be guided by the preoperative ultrasonography, whether 2D ultrasonography or 3D ultrasonography, that confirmed that adenomyosis is superficial near to the myometrium. But if it is diffuse in the whole myometrium, endomyometrial resection is useless and may be harmful and dangerous. You may perforate the uterus, you may occlude the glands and invade them inside the myometrium with predisposition to inflammation and subsequent malignancies, and the patient will not get benefit because the symptoms will continue. So please, before doing endomyometrial resection, we have to confirm that the adenomyosis is just superficial near to the endometrium, not in the whole myometrium. We can do laparoscopic resection of cystic endometriosis or symptomatizing endometriosis, particularly in patients with IVF-XZ who had a history of failure despite transfer of high quality embryos. Also, ultrasonography can be used, but therapeutic ultrasonography, when we focus high intensity ultrasonography waves to the lesion, it has been tested for myoma and adenomyosis as well. And one of the promising and considered as a future line of treatment for adenomyosis in many cases who desire preserving uterus is to perform uterine artery embolization. And we should know that thanks to radiologists, we have two important advances in the topic of adenomyosis. First advance is description of the junctional zone. The second advance is the introduction of uterine artery embolization to control bleeding and pain by injection of substance to the uterine artery bilaterally to induce occlusion of the uterine arteries, and this procedure can be done under local anesthesia and sedation, and it is considered a simple procedure, and many cases improved after this procedure, and some of them got pregnant, and it is not a contraindication to fertility management later. In this case scenario, I'd like you to put adenomyosis in your mind when you are examining a patient who is around 30-year-old and coming with a complaint of irregular and heavy menstruation, metrorrhagia and menometrorrhagia, with the presence of severe cyclic pelvic pain, which means central pain and coming in a cyclic matter, but it has a character of being severe, piercing pain, central pain, in addition to dysmenorrhea and deep dyspareunia. And deep dyspareunia means the cause is inside the abdomen, not superficial, inside the vagina or cervix or the vulva. On vaginal examination, you discovered that the uterus is bulky, is enlarged and tender and soft, with extreme soreness on movement from side to side. I'd like you to examine a case with adenomyosis by vaginal examination. You will not forget this disease because the patient will cry from pain due to soreness, extreme soreness of the uterus by the congestion and by the adenomyosis and myohyperplasia. So by pelvic examination, you detected a central mass, no palpable adnexal masses, no possibility of ovarian tumors, ovarian endometriomas, pedunculated subserous myoma or whatever. So the lesion is central with extreme pain, and the patient has menometrorrhagia, severe pain, and she is around 30-year-old. What do you expect this case? The expectation is a uterine mass, but it should not be myoma, because myoma is not associated with extreme pain, except in some cases like red degeneration, which occurs as a complication of myoma during pregnancy. But otherwise, the myoma is not extremely painful on vaginal examination. So consider adenomyosis in this age group and in this type of patient. You have to do ultrasonography. 2D is quite sufficient. Sometimes 3D and Doppler are needed, and sometimes MRI is required to confirm the diagnosis. And after confirmation of the diagnosis of adenomyosis, we have to ask the patient, are you willing to have babies or not? If not willing to have babies, you can offer her medical treatment like progestogens, like GnRH agonists, like COCs, like danocrine, like IUD intrauterine system. If failed, we can offer her surgical treatment whether uterine artery embolization if she desires to preserve the uterus, or hysterectomy if she is not desiring to have a uterus inside her body. The second group, we have to ask the patient if they need to have children. The answer is yes. So we have to perform infertility workup for the patient and her husband, and after evaluation for fertility we should do hysteroscopy, and hysteroscopy, if detected no factor of infertility inside the uterine cavity, we have to offer her assisted reproductive technique like IVF, ICSI, or to offer her laparoscopy if endometriosis is suspected. As I told you, endometriosis is commonly associated with adenomyosis in up to 80 to 90% of cases. If you suspect also adhesion, you can offer your patient a hysteroscopy and laparoscopy, which is a combined technique, to deal with these problems. If they are free, again you can offer her assisted reproductive techniques. In conclusion, adenomyosis is a common but underestimated and under-recognized pathology. It is a clinical entity. It is not a subtype of endometriosis. It is a separate disease. We have to respect it. We have to consider it in dealing with any patient with the complaints of adenomyosis. It has a deleterious effect on the uterine, on the IVF results and reproductive outcome of the females. So we have to take care of this disease. It affects the results of the IVF and the reproductive outcome of those women who got pregnant after diagnosing adenomyosis. At present, the role of an optimal treatment options for women with adenomyosis and infertility remains unknown. Screening of adenomyosis might be considered before assisted reproductive techniques, and counseling of women with adenomyosis about the prognosis and the lower pregnancy rate with adenomyosis should be done. Pre-IVF treatment with GnRH agonist downregulation may be beneficial to improve pregnancy rate, and particularly for frozen embryo transfer. Uterine artery embolization is a promising, attractive alternative to abdominal hysterectomy in women desiring to preserve their uterus. If you like this video, please press on the like icon. If you desire further publications, you can press on the notification and subscribe icons as well. Thank you very much.